Hello, everybody, and welcome to our latest episode of Let's Chat About Aging in Your Community. This program is brought to you by CHATS, Community and Home Assistance to Seniors. And while we're a regional organization, the topics that we discuss really have relevance to aging in the much broader community as well as across Canada. And today we are so delighted to welcome Dr. Samir Sinha, who is one of the leading experts in the field of aging. And we're really delighted that Dr. Sinha has agreed to join us today. He's a geriatrician and a clinician scientist at Sinai Health System and the University Health Network in Toronto. But he's also director of health policy at the National Institute on Aging and a professor of medicine at the Toronto Metropolitan University and the Johns Hopkins University Schools of Medicine. It really is rare that you won't see some kind of article, broadcast, or conference where Dr. Sinha isn't one of the speakers on aging and how we could become a more age-friendly country, in fact. So, welcome to the program today, Dr. Sinha. And I guess the first question that I have is at a time when geriatrics is not necessarily, a lot of physicians are wanting to be trained in, what motivated you to see this as a career opportunity?
Well, first of all, thank you very much again, Christina, for the generous invite to be on the Chats podcast. It's an honor to be here, and it's an honor to share some of my views and to have a chat. So first of all, thank you for that. And it's interesting because when people ask me what got me motivated into geriatrics, I remember one reporter from Maclean's early on in my career, described me as a person who preaches geriatrics with evangelical zeal. And I thought, what a great description, because when anybody asks me, what type of doctor I am, and they hear geriatrics, I'm like, I don't understand that. I have to always frame it into things that people are more familiar with, like pediatrics. And they're like, oh yeah, no, we all know about pediatricians. They care for young people. I'm like, well, exactly. So I'm a physician who does a similar role, but for older people, often those in particular who are frail and vulnerable, but also those who are looking to, maximize their opportunities to age as well as possible and with confidence. And so, but geriatrics is still one of those things that seems a bit of a mystery, because the New York Times actually declared my specialty of medicine. They called geriatricians a rare and endangered species of physician, because when you look at the number of us in relationship to, for example, pediatricians, while we have more older people in Canada now than younger people, and that's been for well over a decade now, we have 10 times as many pediatricians as we do geriatricians. And unfortunately, our numbers are not climbing quickly enough to really adequately meet the needs of older people. So I understand why many people may not have heard about my specialty and that we exist. But why did I go into geriatrics? Because when I went into medicine, I wanted to work with vulnerable populations. And it was a mentor of mine early on in my career who said, there's no more faster growing vulnerable population than older adults. It's not to say that all older adults are vulnerable. Older adults are, a growing segment of our society. Many people are living healthy and independent lives, but they're at increased risk for having things that can get in the way of aging well, and particularly those who might be frail and vulnerable. If we don't really have everything in place, not just from a health and wellness, but also a social well-being and a financial security aspect, then there really could be a lot of missed opportunities to allow that person to age well and with confidence. So that's a little bit about what I do, a little bit about why I do it, and why I'm so excited to be a geriatrician.
Now, you led Ontario's senior strategy and also contributed to the national senior strategy. What were some of the more transformative recommendations coming out of those initiatives?
Yeah, so that's well over a decade ago when I was tapped by the government of Ontario to help develop Ontario's first senior strategy, and something that we then updated in 2017. And that was a really incredible opportunity, because you have to remember the context. In 2011, our baby boomers were just starting to turn 65 years of age. By 2031, those first baby boomers are going to start turning 85 years of age. And we're now looking at a quarter of our population being 65 and older. Already this year, Canada will have 20% of its population now become 65 and older, which will actually rank us as a super aged nation. So, in that respect, we need to think about aging as an incredible, challenge and opportunity at both the national level, but actually at a provincial and territorial level. And so in 2012, when I was tasked with helping to lead, this process in terms of how would we develop this, it was incredible. They had me travel across all parts of the province, from Toronto to Windsor to Ottawa, and all the way up to our most northern First Nations community, Peawanuck, for example, or Winnisk, to really just dialogue with older Ontarians, but caregivers, care providers. And we came up with 166 recommendations, and really that affected 10 different ministries in the government of Ontario at that time, really talking not only about how do we help people stay healthy and well, and how do we develop age-friendly communities, but also thinking more broadly, how do we provide support for caregivers, and how do we make sure that our system is better enabled. And so what was nice to see was that as the government was keeping track of the recommendations, and progress towards that recommendations, they actually have made progress on most of the recommendations. Is it the progress that I'd like to see? Is it the transformative change that I think we actually need at the moment? I wouldn't say fully, but what's really cool is looking back at much greater investments in home and community care, community support services. To the level I want, no, but better than what we had before. And some really new cool models that were just ideas at the time, but through the senior strategy, we've really empowered, like our community paramedicine programs. They're now
Hmm.
available across the entire province, and really help recognize the value that even paramedics can play in really helping older adults stay healthy and independent in their own communities. So I could talk about a bunch of things, including the dozens of more communities across our country that have now achieved World Health Organization age-friendly status, including the City of Toronto, where I remain as the co-chair of our senior strategy. And even at that level, the municipal level, at the provincial level, we've been seeing some nice changes that have occurred, that are better enabling and supporting older people. But I would say that I think this government has a lot of work to do, because since this new government has been elected since 2018, we haven't actually had a new senior strategy. So we're resting on kind of progress that was made over a decade ago, but there's a lot more work that needs to be done.
Yeah, that's certainly something that we're always advocating as well, that, there's a lot of focus and attention right now, and quite frankly, money being spent on, developing long-term care homes and building new long-term beds, as they're often referred to, which, certainly is something that's needed and necessary. But our concern sometimes is that it's at the exclusion of also focusing on improving community-based care and helping people to stay in their own homes and in their own communities. Is that something that was a big part of the initial strategy? And you mentioned that was over 10 years ago. So if that's the case, then why are we lagging behind and really helping to promote more investment in community-based supports?
Yeah, Christina, thank you for asking, because that's the multi-billion-dollar question, I would say. So again, I'll take you back in my time machine, over 12 years ago now, and you may have recalled that around 2007, 2010, there was some earlier work done on the aging at home strategy, and that was where there were
Mhm.
some significant investments made at the time to bolster the provision of community support services, really recognizing the power of the community to really support people to age in their own homes for as long as possible. And what we saw was some promising developments when you provide more supports that allow people to age in their own homes and age in their communities, then there's less of a demand for people to end up needing to move to a long-term care home, which ultimately ends up being a much more expensive option for all of us as taxpayers. And so when I was actually looking around and seeing how other countries were really addressing these issues, one country I really seized upon was Denmark, where they actually really kind of took a look at the way they were providing long-term care services. And when I mean long-term care, I don't mean just nursing home beds. I'm talking about that whole continuum of care. And what they really did starting in the late 1980s is they said, look, if you ask any older Dane, and I'd say if you ask any older Ontarian, any older Canadian, where do you want to age? Literally 100% of people say, I want to stay in my own home and
Mhm.
community for as long as people. I heard that from my patients in downtown Toronto to, again, up to the most remote First Nations communities that I got to visit as well. Like that's a universal thing that crosses all cultural contexts and boundaries. And so when I showed the numbers and the data, I convinced the then Minister of Health, Deb Matthews, to say we need to really bolster our home and community care spending. And so at that time, we actually started bolstering the budget, not just at inflation, but over 5% year over year increases in the home and community care budget. And what we started seeing was we had more nursing home eligible people in Ontario that we were now supporting in their own homes within 5 years than actually were living in long-term care homes because we had more home care available. We had these home first programs. We had ways to really get people out of the hospital and back in their own homes and communities, or keeping them in their own homes and communities and keeping them out of hospital. And that's where community paramedicine was also part of that. So thinking just beyond traditional delivery of home and community care services, what more could we do to bolster community support services, home care services, community paramedicine, even the greater provision of home-based primary care? And we really saw a really, really nice growth in the number of people and a much greater stabilization in just the demand for long-term care
Mhm.
beds by frail older adults. So we have all the data. It's quite compelling. I have a beautiful slide that kind of puts it all together. But unfortunately, when we had a transition in government, I remember they continued me on, so I don't belong to any political party. So, Doug Ford's government, invited me to stay on as the seniors lead and asked me for my advice. They said, look, should we be building all these new beds? And I said, as you just said, of course we want to redevelop older beds. We want to make sure that there's some places that need beds. We need to do that, but I don't think we need 30,000 new beds. I think what we need to do is continue to bolster our support of people in the community. Unfortunately, again, I just give advice. I don't actually make the ultimate decisions. They decided to instead they discontinued those 5% plus year over year increases in the home care budget. They moved that back down to just simply inflationary increases at most. And what we started
Yes.
seeing was then all of a sudden, with less money available, as our population kept aging and more people needing home and community care, our hospitals were now filling up again. Our ALC issues that we call them, started to become a problem again. Our nursing home wait list started to rapidly creep up. In fact, the government doesn't even report the numbers anymore. It used to be about 32,000 people in 2018 on the nursing home wait list. My
Mhm.
latest word from Ontario government officials was that it's probably closer to 70,000 people now waiting. And in all this money, billions and billions are spending to try and get beds opened and developed. Since 2018, at the last reported count from the government, they've only redeveloped or opened brand new, maybe 5,000 beds in total. So, and meanwhile, people are waiting for more home and community care and other support. So we actually have great evidence from what other countries around the world have done. Denmark's a great example where they've stayed the course. They put the majority. They spend a lot more on long-term care services than we do, and the majority of their funding is focused on providing people care in their own homes and communities, but making sure high quality nursing home or long-term care services are available for those who ultimately would benefit from that as well. So we actually know what we need to do. um, I pitched all of this to the current government. They've decided to stay the course and just build a lot more long-term care beds. And when there was a national competition a few years ago, the Hunter Prize for Public Policy, saying, what's the number one idea to help reduce our ALC crisis and in Canada? I put together the proposal I put for the government with some colleagues, and we won the number one prize out of 200 submissions, saying investing
Wow.
more in home and community care, in what we were actually calling virtual long-term care, where you're not doing it in physical nursing homes, but actually delivering that level of care in people's own homes in partnership with community support service agencies, primary care providers, and also community paramedics. We demonstrated, with the math, that you could probably care for people in a more cost-effective way in their own homes, providing what I call virtual long-term care, versus actually having to warehouse people in maybe big institutional settings where people often don't want to be. So,
Right.
again, I can only give advice, and I can't really, I don't, unfortunately, I'm not the one making the decisions. But I recently got to advise all the premiers of Canada. They invited me to give them some advice on what they should be doing around elder care. And they said, if you could do one thing, and I said this to Premier Ford and all of his colleagues, I said, if you could do one thing, I would double the home and community care budget in your province tomorrow. You do that one thing, it's going to help reduce the demand for nursing homes, and it'll actually get a lot more people who are languishing in hospitals back into their own homes where they actually want to be. So I'm waiting for people to take me up on that challenge, but the message still stands as much as it did back in 2012.
Well, that's a fantastic message, and certainly one that chats echoes in any advocacy efforts that we undertake as a community support organization. We're providing assisted living for high-risk individuals very successfully, keeping them out of long-term care longer. We're working with our hospital partners to ensure that elderly patients can be discharged home sooner, but with the kinds of supports that will help them to thrive, and support their family caregivers to keep them at home as well. We're currently looking at are planning to open an overnight respite care center for individuals with dementia. It's called Chiba Place, and we're going to be operating that mostly as support to family members who just need to have a break for a few nights or a few days. And we're very excited about that. And I think, to your point, there's so many examples and models of how successful we are being in supporting older adults and their caregivers. And yet, we're constantly finding ourselves in a position where we have to advocate for that investment that you've talked about. And we get the nods and the sort of polite responses saying, yes, you've got a great narrative, but there's no evidence. And you mentioned several times that the evidence is there.
Oh, the
I
evidence
know
is
that.
there, and it's overwhelming, Christina. Yeah, like, I mean, it's absolutely there. And just if there's one number, like when the people ask me, like, what does it cost, to to build a long-term care bed. Well, now people are saying they need at least $1 million to build a bed, for example, right? The government's now providing well over $500,000 to build each of these beds when it used to cost $250,000. So we know construction costs, land costs, all that are rapidly expanding. And that's just to build the physical bed. That's not even to provide the care within it. But when you look at the cost of providing long-term care services in a nursing home, it's about $200 a day. When you look at care for people who are in hospital waiting to go home or to another place, that's about $750 a day. And when you look at high intensity home care for long-term care eligible individuals, it's about $100 a day. So these are the ministry's own numbers. These are their own numbers that they regularly share with me, they regularly update me on. And again, you just have to look at other jurisdictions that have done this. Once after Denmark had done this, for example, Denmark and Canada were originally spending about the same amount on healthcare overall. Now they spend about 40% of their healthcare costs on providing this range of what we call long-term care services. But by doing that, by really investing in the care of older people in with dignity and the right supports in their own communities, their overall healthcare costs have significantly decreased because they don't actually have an ALC issue. They don't have people languishing in hospitals because they're like, people have their own homes. And if they don't have their own homes, we find them a home, right? And there's so much more we can do today to provide care for people in their own homes than we could even 10 years ago or 20 years ago. So it's amazing what you can do when you harness the power of the community, when you support families and their
Mm.
caregivers and you support individuals to do what you can, because you can lower your overall healthcare system costs. Because Denmark not only actually avoided building any new nursing home beds for over 20 years once they started making greater investments in the home and community care sector, but they actually closed thousands of hospital beds. And it's wild. You now go to Denmark and you actually meet with a hospital CEO. They always love to show you these models of the next version of their hospital. And they love to play this guessing game. Now, in North America, the guessing game is if it's a 1,000-bed hospital, then they want you to guess. And generally, you have to guess up because they're saying, well, I'm building this empire. And look, this new hospital will be 1,200 beds. In Denmark, it's a guessing down game. They're so proud to tell you that their 1,000 beds is going to be reduced to 800 beds because there's so much more medical and other forms of care that can now be delivered in people's own homes, with the hospital actually working as a hub as opposed to a repository for all these people. So it really is it's a mind shift that we need, because right now I can tell you, things are only getting worse. And it's just an increasing struggle for me to get my patients the home care services they need. When I talk to organizations like Chats, they want to do more. They're excited to do more, but they just don't have the funding and the supports.
Mhm.
And frankly, um, we're not heading in the direction that we need to head in. But again, I'll just keep saying this over and over and over again, because repetition, eventually it'll work. And the evidence continues to mount, and we'll eventually we'll figure it out.
Mhm. Can we talk a little bit about artificial intelligence and how that is now becoming a way of, I guess, maybe enhancing care or supplementing the way in which care can be delivered?
Yeah, I mean, I had the real privilege, as you know, over the last year of being invited to spend a year at the University of Oxford. I was there 24 moons ago as a student, where I did my master's and PhD, where I actually looked at the provision of integrated health and social care for older people. And now I was invited back to be a member of their Center for Ethics in AI, and as an AMS fellow in compassion and artificial intelligence, to look at how do we harness digital technologies, including AI, to better support the care of older adults. And I wouldn't say it's AI per se. I'd say that there's lots of technologies, some that can be enhanced with the use of artificial intelligence, that are now being developed that support things like home monitoring, allowing people to be better connected, through virtual care and other methods, so that they can get more care in their own homes, or they can be better supported that way. I think AI is kind of exciting. It's sexy, for example, but we also have to be wary about how we harness it in different ways, in terms of, people are now using it, for example, to help, home care organizations, for example, with the scheduling of their work, for example, or creating better routes so that you can, better serve more people, in less time, if you will. People are now using it, increasingly as a care planning tool, or to help with
Mhm.
note taking, which is often kind of a thing that is the burden of all of our existence as healthcare providers. But we always want to make sure that when we're using these, like, AI scribes, or some of these other methods, we're making sure that, how is this data being used? How are we protecting the privacy of our healthcare or social care providers, and the people, the vulnerable people that we're serving? And how do we make sure, that we're using, AI in ways that's going to promote, and support older people, and not necessarily disadvantage them? Because a lot of these large language models, for example, that are being used, for example, are often fed data that's not representative of older adults. Sometimes it has a lot of ageist comments, and stuff there, because it just sucks up what we as society think of older people, which on balance is not always super positive. And so we always have to make sure that
Mm.
as we're developing AI systems, it's representative of the frail older adults, that are part of our society. It's respectful, and it's not disadvantaging them. And that we're making sure that we are securing people's data, in a way that we're not using it in a way that could ultimately be used to harm them, but support them.
Mhm.
Because there's a lot of exciting developments in AI, but unfortunately, there are a lot of bad actors out there who are using AI to create deep fakes, so that they're using that in scams now, digital scams that can target an older person, for example. So you now get a phone call and you hear your grandson's voice saying, Grandpa, I need money. Please send me some gift cards right now. And it's their voice, but it's been manipulated using this technology. So we have to just kind of be mindful. And the challenge we have right now, Canada doesn't have an AI Act. Only the European Union has an AI Act right now. And so without any clear regulation, it makes it harder for citizens to know that they're being protected, in this Wild West environment that we
Mhm.
have.
Mhm.
It can actually put providers like Chats and other organizations at risk as well, if we're not making sure that there's clear guidance and regulations and support, so that we're using this effectively, and safely and responsibly in the care of older people. So I'm excited, and I think there's a lot of neat ideas out there, but we need to make sure that as we're using AI and other digital technologies, we're trying to enhance, kind of the care that we're providing, and not necessarily use it, to make people more socially isolated, and or potentially, disadvantaged in the care that they need to receive.
Mhm. That's great advice, and particularly to us, because it is an area that even within our sector, we're looking at what are the advantages, but also where are the areas we need to steer a little clear of, so as not to either put our own organization and staff at risk, or our clients. So great advice on that front. Just like to turn now, we've only got a few minutes left. Our time has gone so quickly, but I want to talk to you a little bit about, the efforts, that are going on right now within the healthcare system to ensure that people are connected to a family physician. And in that effort, whether you see any opportunities for organizations like Chats within the community support services sector to become better known to family physicians and primary care, so that we could also support that effort.
Absolutely. I mean, I think the key is, like, when we start thinking about, the power of the community and how we can actually really leverage that as best as possible. I think a lot of the work that we've done through the National Institute on Aging, focuses on, that how do we strengthen the provision of long-term care services, overall. But we've written, reports, related to, what naturally occurring retirement communities and kind of promoting
Mhm.
those as kind of ideas and concepts where you can cluster care and provide better supports for people. We've talked about what other countries are doing to leverage postal workers, who deliver your mail to do friendly check-ins and visits, for example. And now we're actually developing a whole uh, policy report around the power of the community support services sector. So groups like Chats that do caregiver supports, that do socialization, friendly visiting, meals on wheels, adult day programs, all these sorts of things that go beyond the traditional provision of primary care services, what you might get at your family doctor or nurse practitioner's office versus and what you get beyond traditional home care, which is very specific in what they provide. So the
Mhm.
challenge is that, as you noted, you've got very, very busy primary care providers, for those of us lucky enough to have one, who are really just trying to coordinate, your medical care, but they often don't really know about all the other services that are out there. And so certainly, Jane Philpott, who's been appointed in Ontario as our primary care lead, I've met with her a few times to talk about, specifically how do we enhance the care of older people. And things that we need to do is we need to make sure that, first of all, that older people are connected to primary care services. The NIA's work has shown that maybe upwards of a third of older people don't have regular access to a primary care provider. That's a problem. So we need to get everybody connected. But especially if you're frail and older and maybe more vulnerable, it's important to be cared for by a team. Because it's not just often the medical issues that you might have. You might have
Mhm.
medication, you might have social issues, other things that need to be better connected. And being a part of that team can extend to being connected better to home and community care services, community support services, and that. So I know I was talking to the head of Ontario Health at Home recently. I've been talking to Dr. Philpott as well, about how do we finally start creating, real networks where, again, if people, we don't need to have our doctors know everything that's out there, but we need to be able to say, if I have a person who may have a need, maybe there's a member of my team that has this knowledge, knows how to connect people, so that organizations like Chats, for example, are there and ready and able to be supportive. So there are things that we can do. I think the problem that we often have is that that everyone's so busy being busy. People aren't as well connected. That I think there are ways in which we can get in these new developing Ontario health teams and that it very clear so that that there is no wrong door, that Chats, for example, has a mechanism to identify people who don't have primary care and get them connected, but also be seen as a real partner in the provision of that care in our own homes and communities as well. So I think there are ways to do it. And I think there's some early thinking going on about how do we finally get things connected. I've certainly wrote about that. When I was asked for my advice around this, I said, hey, here's a copy of my report from 2012. I had it all worked out. So they're like, oh, you have done some thinking about this. So it's great when you put something down on paper because it may not be the time when people want to take action, but certainly what you're talking about, Christina, is things that we need to do to better get people
Mhm.
connected to primary care, home and community care, community support services, so that
Yep.
people can age independent and in their own communities for as long as possible.
Dr. Sinha, I want to thank you so much for being with us today, for just the deep insights you've provided, your compassionate vision for how we can and need to improve elder care and supports in Canada, that the opportunity is here and now, and that we really do need to make those changes, and certainly that there are many organizations like Chats and others that are willing to step up and follow through on the many recommendations that you've been putting forward for such a long time. I think the time is now. I'm one of those baby boomers who has you know is closing in on that peak, and certainly I want to be sure that that I'm able to leave a legacy as well for the people behind who will be needing elder care at some point, either for themselves or their family members. The work that you do is truly essential, and on behalf of all of us, I thank you for what you do. So we really appreciate you being here.
Well, thanks for again for having me, Christina. Thank you for being a member of the Coalition of the Willing, and yeah, we'll just keep doing what we're doing. We'll keep putting forward good recommendations. I'm really proud to be leading an incredible team of health policy researchers at the National Institute on Aging, as we continue to gather the evidence, make the recommendations, really make it clear, so that we can figure out what we need to do as well.
Well, thank you. And thanks to all of our listeners and viewers who joined us today for this chat about aging in our community. And we'll see you next time for more conversations on the matter.